Good morning. It's a great honor to contribute to the 17th National Russian Dialysis Society Conference. In the next 25 minutes, I will give you a summary of the key areas of the updated KDIGO AKI Guideline. I'd like to take you back to 2012, when this landmark paper was published. And it included more than 90 recommendations based on review of more than 18,000 citations. It summarized the existing evidence based on data until 2011. And it had important recommendations that shaped clinical practice and also research in this area. The key areas of the 2012 guideline were acute kidney injury diagnosis, prevention and treatment of acute kidney injury, prevention of contrast-induced acute kidney injury, and recommendations related to the management and practice of renal replacement therapy. Of note, this was the guideline that informed us of the definition and criteria of acute kidney injury, as shown here. Since then, we define acute kidney injury based on a rising creatinine or a fall in urine output. At that time, in 2012, there was not enough evidence and there were not enough data to incorporate any biomarkers in the definition. But obviously, a lot has happened since, and as shown here, many biomarkers have been detected, and a lot of publications are available now in the literature with focus on the role and usefulness of acute kidney injury biomarkers. Just as a reminder, biomarkers are substances that are released by different parts of the kidney, different parts of the nephron in response to certain exposures and triggers. And they give us different information about the structure, the degree of damage, or the role of these particular parts of the nephron. And a lot of studies have been published showing that different biomarkers can give us information about the etiology or the pathophysiology of acute kidney injury. And they can also give us information to risk assess patients and prognosticate. And with the help of these new biomarkers, we've certainly become aware of a state of subclinical AKI. It describes the phase of acute kidney injury before a creatinine rise is detected. And clearly, biomarkers can help here identifying high-risk patients, as you can see here, where we have two cohorts of patients in whom creatinine has not risen yet. But as you can see here, depending on whether the biomarkers are positive or negative, different outcomes have been observed. And certainly patients who had a biomarker rise were characterized by a much worse prognosis. Since 2012, we've also had a lot of research looking at the epidemiology of acute kidney injury, and we've learned that different trajectories exist. Different patients with acute kidney injury may have different outcomes. Some patients recover acute kidney injury very quickly. In others, it takes longer. And some patients initially recover kidney function, but then develop acute kidney injury again, so have recurrent acute kidney injury. And a proportion of patients with acute kidney injury never recover kidney function and progress to chronic kidney disease and sometimes even end-stage kidney disease. We also now appreciate the importance of acute kidney disease, which essentially describes the whole period from beginning of acute kidney injury up to day 90. Acute kidney injury itself is just a part of acute kidney disease. It's a period which has been described as lasting up to 7 days. And it's part of the whole phase of acute kidney disease. And like acute kidney injury, different trajectories have been observed in acute kidney disease. And they depend on many factors related to the patient, comorbidities, and factors related to the trigger of acute kidney injury. But it's certainly a phase that links acute kidney injury to chronic kidney disease. Landmark key work conducted in Canada has shown that acute kidney disease is actually more common than acute kidney injury. And in fact, there are some patients who develop acute kidney disease and progress to chronic kidney disease without having a period of acute kidney injury. And again, this work is very important and informs research related to acute kidney disease. So the new guideline will touch on all these areas and aims to define persistent versus transient acute kidney injury and relapsing versus recovered acute kidney injury. It will also incorporate the role of biomarkers and provide criteria for the diagnosis of subclinical AKI. And lastly, it will also acknowledge the fact that a lot of acute kidney injury occurs outside the hospital setting, and that it's important to differentiate between community versus hospital-acquired acute kidney injury. The 2012 guideline had a long section on risk assessment with the aim to identify high-risk patients in hope that interventions could be detected to prevent acute kidney injury or to prevent progression of acute kidney injury. And at that time, only a few tools were available, but the expert team referred to risk scores as shown here. And a lot of scores were available, but they predominantly related or referred to high-risk group patients undergoing particular procedures like cardiac surgery or coronary angiography. Since 2012, we've identified many new risk scores and risk tools to identify high-risk patients. And there's certainly the renal angina index, which has been described in the literature. We have more information about the assessment of renal functional reserve. And there are biomarkers that help us identifying high-risk patients. More recently, advanced statistical tools have been discovered, statistical strategies and methods like latent class analysis that have helped identifying patients at highest risk of poor outcomes. Here, for instance, is a study confirming the importance of renal functional reserve assessment, work led by Professor Ronco. And here you can see the two extremes. So patients with very little renal functional reserve, with a renal functional reserve of less than 10 mils per minute per meter, 1.73 meter square, had a almost 100% risk of developing acute kidney injury after cardiac surgery, compared to patients with normal renal functional reserve, as outlined here on your right, where no patient developed acute kidney injury. And knowing patients' underlying renal functional reserve helps identifying the high-risk patients, but it may also help identifying patients in whom particular strategies during surgery could be beneficial. As already mentioned, biomarkers may also help to identify high-risk patients. Here I show you a study where the team used cell cycle arrest biomarkers to identify high-risk patients. And again, as shown here on the right, patients with acute kidney injury had a different prognosis and different risk of mortality depending on whether they were also biomarker positive or not. We've had various studies since 2012 where biomarkers were used to identify high-risk patients and to then implement certain strategies. I'd like to mention the XVII study, but also the XXIII study, which compared intervention strategies in high-risk patients as identified by biomarkers. The similar strategy was used in the Big Pack trial and also in various observational studies investigating renal bundles. Biomarkers have been identified that may even identify high-risk patients before the intervention. And as an example, we have urinary biomarkers, the DKK3 biomarker, which informed clinicians prior to cardiac surgery of patients who are at high risk of subsequent kidney function loss after cardiac surgery. So all these new studies and new insight will underpin the updated KDIGO AKI Guideline with a focus on looking at new tools for risk assessment, looking at recommendations for patients who are scheduled to be exposed to procedures or particular high-risk exposures like drugs or contrast. And it will also focus on or touch on new tools like electronic alerts, warning scores, and digital tools. As I've already mentioned, the management of acute kidney injury was an important part of the AKI guideline in 2012. And at that time, this stage-based approach was advocated, as it is well known to clinicians. Fluid management and hemodynamic optimization form part of this staged approach. And at that time, in 2012, the expert committee recommended to use crystalloids rather than colloids, but they also acknowledged, as shown here at the bottom, that more research was necessary and that different types of fluids should be researched and investigated in future. Now, these studies have obviously been done, and we know that we've had the SPLIT trial, we subsequently had the SALT-ED and SMART trial, which concluded that buffered solutions were better than saline. But unfortunately, the subsequent two trials, the BASICS trial and the PLUS trial, were not able to repeat these conclusions. And in a subsequent meta-analysis published only last year, again, there was a signal in favor of balanced solutions or buffered solutions, but it was statistically not significant. Certainly these trials, together with trials looking at volume, will underpin the new guideline. When it comes to volume, we now appreciate that both hypo and hypervolemia are harmful, but we've had conflicting data related to the benefit of restrictive fluid. As a reminder, the RELIEF trial looked at restrictive versus liberal fluid therapy and showed an increased risk of acute kidney injury in patients randomized to the restrictive arm. The subsequent classic feasibility trial and also the subsequent main classic trial showed no signal of harm. Similarly, the recent CLOVERS trial, looking at restrictive fluid management, showed no harm from restrictive management. And so these data related to type of fluid, volume of fluid, and also method of administration and monitoring will indeed be included in the new updated guideline. I've already said that hemodynamic management is an important part of the current acute kidney injury guideline. And at that time, the expert committee recommended that vasopressors should be used to keep the target blood pressure at around 65 to 90 millimeter mercury. But it was acknowledged that more research was necessary. Since then, we've had trials comparing different blood pressure targets. And certainly this trial, looking at patients with septic shock, showed no real difference between two blood pressure targets, apart from these subgroup of patients with chronic hypertension. These patients benefited from being randomized to the higher blood pressure target group, showing a significantly lower requirement for renal replacement therapy. Hemodynamics and hemodynamic optimization are very important in the management and also prevention of acute kidney injury. But we've learned to understand that mean arterial blood pressure is insufficient to monitor and control intrarenal hemodynamics. And the intrarenal hemodynamics are much more complex. If we just look at glomerular hemodynamics alone, here we can see that different vasoconstrictors may have different effects on glomerular hemodynamics and glomerular filtration. And vasoconstrictors that predominantly affect the afferent branch will have a different effect compared to vasoconstrictors with predominant action on the efferent branch. Furthermore, we know that renal perfusion not only depends on mean arterial blood pressure, but also back pressure, also on the renal vein pressure. And an increased renal vein pressure as a result of a high CVP or hypervolemia may impair renal perfusion. As shown here, a high venous pressure may lead to compression of the renal veins, increased intrarenal edema, and intrarenal congestion, all contributing to acute kidney injury. So we don't know the optimal mean arterial blood pressure. And in 2012, it was also recognized that we didn't know the optimal vasopressor to prevent and manage acute kidney injury. We still don't know the optimal vasopressor, but we do know that different vasoconstrictors act differently on receptors within the kidney. And clearly some work is already happening, but more work is necessary to evaluate these different vasoconstrictors in the setting of acute kidney injury. So the revised, updated acute kidney injury guideline will touch on these areas and address the blood pressure targets, the optimal hemodynamic management, and the preferred vasoconstrictor. It also aims to address hemodynamic monitoring of patients with acute kidney injury, and the question whether hemodynamic management needs to be individualized in different patient cohorts, for instance, patients with chronic hypertension. Now, drug management is an important component of the existing guideline. And as you may know, at that time, the guideline focused particularly on aminoglycosides, amphotericin, and contrast. And it issues the guidance as shown here. It recommended against aminoglycosides unless they were absolutely needed, and if needed, it was recommended to use a single dose rather than multiple doses. And at that time, it's recommended to use intravenous fluids, either saline or sodium bicarbonate, together with N-acetylcysteine to prevent contrast-associated acute kidney injury. With regards to contrast-associated acute kidney injury, we've learned a lot since 2012, and certainly the PRESERVE trial, a landmark trial, has taught us where there is no real benefit of bicarbonate over saline, and there is no role for N-acetylcysteine. And this has certainly gradually influenced recent clinical practice. With regards to drugs, we now know that not every drug that causes a creatinine rise is nephrotoxic, and certain drugs may still be recommended even if associated with a creatinine rise. We also know that drugs act differently on kidney function and nephron and the structure. So certain drugs have a predominant damaging effect on tubular cells. Others have a role in, or others impact kidney function by reducing glomerular function. And there are certain drugs that do both, i.e. damage tubular cells and also lead to impaired kidney function. And this more detailed knowledge about drugs and the effects on kidney function and risk of acute kidney injury is very important, but also means that in future, drugs need to be classified accordingly. As I already mentioned, there are certain drugs that may lead to a creatinine rise, but has to be accepted. And certainly this applies to the role of ACE inhibitors in patients with heart failure, for instance, where the overall benefit of ACE inhibitors overrides the potential risk of a creatinine rise. And certainly this nuanced knowledge is important and will feed into the future AKI guideline. So the aim is for the updated guideline to look at different ways of categorizing drugs, to issue some guidance on the use of certain drugs in high-risk patients and in patients with acute kidney injury, to comment on particular drug combinations, and to give guidance on how to monitor drugs in patients with acute kidney injury and when to initiate potentially nephrotoxic drugs again. And finally, we'll look at the role of electronic alerts to prevent drug-associated acute kidney injury. I've already mentioned renal replacement therapy formed an important part, a large part of the 2012 guideline. And at that time, the expert committee recommended to initiate renal replacement therapy when life-threatening changes and complications of acute kidney injury occurred, to base the timing not only on creatinine and urine BUN values, and to consider stopping renal replacement therapy when it was no longer necessary. And at that time, it was clear that the data were sparse and that more data were urgently necessary, in particular data comparing early versus late initiation. This was in 2012. Now, since then, we've had several landmark trials, and as I show you the 5 key trials here, comparing early versus late initiation of renal replacement therapy. They're all landmark trials looking at different patient populations and also using different criteria for early versus late. 4 of these trials showed no real difference between early versus late initiation, but 1 trial was positive. But as I've already mentioned, they were all conducted in different patient populations using different criteria. Furthermore, we now know that timing and initiation of renal replacement therapy not only depend on these particular absolute criteria, but need to be individualized based on the complication and impact of acute kidney injury in individual patients. And these new concepts using the demand or impact of acute kidney injury on patients' endogenous renal reserve is very important. And certainly these new concepts, which allow decision-making, will feed and inform the revised acute kidney injury guideline. And so a new framework, as shown here, will certainly support and help the development of the new guideline. It's been clearly recognized that initiation of renal replacement therapy is a very complex framework requiring different strategies and methods to identify the right time. It's been recognized that this is a shared decision-making process where different stakeholders, but more importantly, also the patient, have a role and have a voice. And that when renal replacement therapy is necessary and considered to be beneficial, then it requires a prescription, which needs to take into account not only the time, but also aspects like optimal modality, dose, type of vascular access, and type of monitoring. And at any time point, it's important to evaluate whether renal replacement therapy is still needed and whether there are opportunities to stop. And the upcoming revised guideline will touch on all of these areas. So we'll look at the optimal timing, the optimal modality, the optimal method of providing renal replacement therapy. When talking about method and monitoring, it will touch on, we'll give guidance on when to consider transitioning and when to stop renal replacement therapy. Furthermore, we'll look at acute peritoneal dialysis as an alternative form of renal replacement therapy and isolated ultrafiltration. And lastly, it's been clearly recognized that acute kidney injury survivors remain at high risk of complications. A lot of work has been concluded since 2012. In 2012, less was known, and at that time, the expert committee recommended that patients should be evaluated 3 months after AKI. Clearly, we now know that this may be too late, and that some patients need evaluations and follow-up much earlier. We know that patients with acute kidney injury have a very high risk of chronic kidney disease, depending on the type and severity of acute kidney injury, but also underlying risk factors. And with that in mind, follow-up clearly needs to be individualized and personalized. And some patients, as shown here on the right, may need immediate follow-up within a week, whereas others with less severe acute kidney injury and less risk factors may only require follow-up a few months later, as shown here more on your left. And the new guideline will touch on these aspects and aims to give guidance on when to follow up patients, who to follow up, and the optimal method of monitoring patients after AKI. And with that, I want to finish. Thank you for your attention. I hope I've given you an outline of the new upcoming guideline. I want to acknowledge and emphasize that our current understanding has advanced in response to the landmark document from 2012, which summarized what we knew at the time and what clearly identified recommendations for future research. These studies have been conducted, so we know more now, and we can now provide and develop a guideline. So thank you very much to everybody who contributed to the current understanding, our current knowledge, and has helped shaping the new updated guideline. It's been an honor to present this. Thank you for your attention.